All right, so welcome back to another episode of Beyond the Practice. Today we're joined by Dr. Ian Madom, the CEO and co-founder of Mockingbird. It's an innovative platform revolutionizing how medical professionals manage their continuing education and licensing requirements. Dr. Madom is also a distinguished fellow of the American Board of Orthopedic Surgery and serves as teaching faculty for AO Spine North America. Welcome to the show.
Thanks, Nick. Thanks for inviting me to be on. I appreciate it.
Absolutely. All right, so we'll start with a little bit of background and the origin story, okay? So, what experiences as a practicing orthopedic surgeon led you to identify the need for Mockingbird?
So, as a doc, I mean, you do have a lot of requirements that happen over time. And at the time, I was actually working on an MBA, and I had a lot of school requirements, didn't stop all of the other requirements that came in from my orthopedic boards or my state licenses, and I carried many at the time. And I just felt just amongst many other activities, I just keep getting pulled away from the bedside from doing more and more things that we now refer to as pajama time, right? Like things, what are the things that I need to do at the end of my day when I get home and I'm not seeing patients to still just be eligible to take care of patients? And sometimes that's charting, right? Sometimes that's actually doing continuing medical education, but oftentimes it's just finding out what is required to be done so that I'm eligible and finding out those things too late in the game just ends up adding to the amount of work. So identified this as a problem with my co-founder George Fernane, who's an interventional cardiologist at NYU. We were in class together and we started talking about this, and if you know what you do, you work with physicians, our favorite pastime is complaining about things. Well, some of us also want to solve those problems. A lot of us do. And we started just thinking about how do we solve this for ourselves? And as we explored the problem more, we realized it wasn't just a problem for us and our fellow physicians. This is a problem for nurses, for NPs, PAs, for dietitians, for everybody who carries any type of expirable license or credential that education sits behind.
So, was there any, like, maybe you answered that there, was that the exact moment where you also decided to, transition from solely practicing medicine to becoming like
Yeah.
a health tech, entrepreneur?
The exact moment came on Memorial Day weekend of 2017. So it was Friday before Memorial Day weekend. I got an email from one of our administrators. These people work tirelessly to support our practices in so many different ways, chasing us down for documentation and stuff. Well, she sent me an email, this huge email that said, "Hey, Dr. Madam, I'm sorry, but by Tuesday, I need 8 hours of opioid training done. Here are 40 different links of things that I could find that might be eligible, you might be able to use to satisfy the requirement. I don't know if any of them are good. I don't know how much any of them cost. I certainly don't know how long any of them are going to take because that's beyond her scope of what she should know. But here you go." And I was like, "Oh my gosh, there has to be a better way," because I know I've taken opioid requirements for other state licenses that I had. This was for my Rhode Island license, and we have to be able to have software that just manages all of this searching costs in the background, find the stuff that I need to do, be able to count those pieces of education towards as many requirements as possible, because doing a piece of education 3 times is not more valuable. It doesn't make me better at doing it. And so that's where the genesis of it became, and started to talk to George further about solving this problem. We had been talking about this, but then when it hit me right in the face a few months later, I was like, we need a solution now.
Yeah. I can relate very much so. There was an instance with one of my license, ART, right, for the technologist. I thought I had to the end of the month. I didn't have an administrator to let me know, stuff like that. So I did mine on November, whatever, 18th, 19th. My birthday is before that. I won't say it on here, but when I submitted them, they flagged. It was a couple days too late. I had to go through more of the process. I even had one with the DOH where they only update their license website every whatever second week or Friday. and I got the call on my actual birthday from my supervisor many years ago saying, "Happy birthday, you could report to work." They updated the website, so it hits at home for me.
It's a problem, as I said, it's a problem for everybody because yeah, I'm blessed as a physician. I'm in an organization where I have those kind of support systems in place. There's many docs that don't at different organizations, and there's certainly many other, like yourself, like my colleagues who are physical therapists, you name it, behavioral health folks that are just they're so busy with the clinical load that all of this stuff falls by the wayside, and then you end up getting to it late. And being late to it has the personal cost, right? It certainly has that stress that now I have to take extra time, cram this into a schedule that I didn't have this actually planned for. But there's organizational cost as well, right? And organizational cost comes, it hits everybody. It hits the administrators that support us, but it also hits the bottom line that if we're not in compliance, that creates much deeper problems for the organization. And we thought of secondarily is that once we figure this out, and we feel like we have Mockingbird is really this platform that manages all of this compliance risk and keeps people on track. It saves we estimate right now that we save clinicians anywhere from 1 to 2 hours a month, right? That doesn't sound like a big lift, but over the course of the year, it's a huge amount of time. What we're realizing is that on the organization side, we're saving those med staff officers 5 to 10 hours a week. And so all of that ends up flowing downhill because now you don't have admins running around wasting clinicians' time with, hey, can you pull this out of your email from someplace as you're in the middle of seeing clinic? That's not even stuff that we've been able to assess because it's these captured moments in time. So we want to move from this great compliance product we have to how do we create the most impactful learning experience for people so that the requirements are there, but the opioid education that Ian Madom has to do as a orthopedic spine surgeon, it's got to be different than the opioid education that the pediatric nurse practitioner who works in the oncology clinic needs, right? Like, but we're just delivering people the same piece of learning. That's not something that I can actually deliver into practice. And so finding how do we hone down on that micro learning and on specified learning for individuals, we're building the baseline for that we can now stock these different types of tools on top of.
It's great. It's fantastic. All right, so expanding a little further, how exactly does Mockingbird streamline, the traditionally complex process of managing medical licenses, certifications, CMEs, etc.?
So we'll onboard a clinician, and most of our business is B2B. We do have some folks that come on in a B2C way, but we are able to onboard people by importing all of their licensure. We do support certain board certifications, and that's something that in 2026 we'll be integrating in more. But your controlled substance registrations, your DEA, any ACLS, BLS, all that kind of stuff gets pulled in. And now, when we know exactly what the different certifications that people have, we're able to match that up against our rules engine. Our rules engine, when we started, was just somebody coding in the actual rules, right? We have now been able to, over the number of years, been able to abstract that and create this abstract rules engine that is able to take a set of licenses and query a database of rules and be able to match specific rule sets for people, so requirements that they have. The specifications that they have, the certifications that they have, they may have to answer a few questions about their practice that will unlock what is the certain pathway that keeps them compliant. And so once they have that, they have this dashboard, they drop in files for learning. Our system has modules that can pull that data off of certificates for people and pulls them into our database and then other tools that takes that and categorizes that automatically. We do something called, we do this through AI tools where we're able to automatically categorize. For me, as a clinician, that's not enough. I want there to be a quality control process. Right now, that quality control process is still people that are able to query and go through files to make sure that things are categorized correctly. In the future, some of that will be automated too. But if I do a piece of learning, it goes up and it gets categorized against all of my credentials and it counts towards everything that it possibly can. And it doesn't count towards things that it can't. Nobody has ever tried to say, oh, I did a piece of education, like that should be enough. There's often people that think that they've done enough, but they actually haven't. A great example comes up in certain states where they require this one specific course to be taken for a certain topic, where other states you can take anything or from a list of 10. And then the other problem that comes up for folks is that, well, I took it in April of 2022. Does it count towards this cycle? Every single state and every single type of certification has a different timeline of window of when those things can be applied. And so we call that cycle to cycle logic. And we have spent years developing that cycle to cycle logic, which is that's probably the most unique thing about our system, so that it applies it and you're taking the right education at the right place at the right time.
I'm enjoying this very much right now. It's a lot of knowledge. I love it. I love it. And I know that was a challenge you just addressed on what's been the most surprising challenge that you've encountered in your journey in automating CME management.
I think that the thing that I didn't realize, I realized it to a small degree, but not as big of a problem as it actually is how fragmented the system is. We hear it all the time, right? Where there are systems that don't talk to each other. We're seeing that in the clinic on a day-to-day basis. Who uses Epic and who uses a different Cerner or a different EMR, and they don't talk to each other. And interoperability is a big problem in healthcare. Well, it's a huge problem in compliance and with CE management because the systems don't talk to each other. And it all falls back on the clinician of saying, this is their problem. So how fragmented and then how brazen some folks who are leadership in some of these healthcare organizations literally said to a doc, this is the doctor's problem. This isn't my problem. And to me, I'm like, that's troubling because we are a resource as clinicians, as healthcare providers. We are a scarce resource. There's just not, you can't just go off the street and get more people. There's fewer people coming into these fields, yours and mine, than we actually need based on the aging population. You can't just say, hey, this is your problem. I'm just going to add to your workload when there are solutions that are there to just simplify it, to create workflows that automate things that really should be automated. It doesn't take a ton of brain power to go search for these requirements and be updated on them, but it takes a ton of time, right? A, you have to know where to go. B, you have to be getting the correct information. C, then you have to go find the correct course to complete it, and then you got to go complete it.
Hmm.
Well, as a clinician, I should just have to complete it. I should just be expected to go learn and be updated in my knowledge base, not spend all this other time if there are systems in place that can help do those other activities. And that's basically what we have focused on.
Yeah.
And that goes into making a better clinician experience. Don Berwick, landmark article of the Triple Aim came out in the 2000s and was the basis of the ACA, right? Of going towards population health. Everybody agrees that population health should be a goal of ours. Improving the clinician experience. I'm sorry, the patient experience has always been a focus. Or wasn't for years, but has been the focus for the past 20 years. And really thinking about value-based care. But they missed that fourth piece, which some folks, I think that were out of Harvard, came out with an article soon after that calling it the quadruple aim. We need to improve the provider experience and building tools that take the burden off of clinicians on the non-clinical side of things. We already have enough burden on us with taking care of patients. That's what we signed up for. That's what I signed up to have the burden of people's pain put on my shoulders and for me to help solve it, right? I did not sign up for more and more administrative paperwork that has nothing to do with an improved patient outcome. And my feeling, and many of my colleagues' feeling, is if you improve the clinician's experience, if you make tools that make their lives better and easier to deliver care, you're going to improve the patient experience because you're going to have a happier clinician that's more engaged. You're going to lower the cost of care and get better value-based care. And you can then start to leverage some of these tools like ours to think about population health. How do we drive better clinician behaviors that are more data driven? It One solution may be putting more pop-ups on an EMR to block people from doing activities. I don't think that works. I think educating people and getting them to make better decisions that are based on the data is the right way to go. So we're really about that quadruple aim.
Yeah, no, that's great. Touching on that, it's for where I was gonna roll next. We're rolling along right here now, touching on the quadruple aim and well-being for the physicians and everything like that. What percentage of time would you estimate, Mockingbird does saves the medical professionals, excuse me, in managing like their credentials? I don't know, you said like 1 to 2 hours, but
Yeah, I think that's a low estimate, right? Like, so just from the things that we can measure and that we've spent time measuring on the amount of time people spend searching for requirements either on their state websites like you did, right? Department of Health. By the way, we spent a lot of time in this. The Department of Health websites aren't always correct.
yeah,
Like we go to the legislation, right? Because there's laws that are passed about this stuff. And why the Department of Health website's not always correct? Well, those offices are often understaffed, right? So they don't have the time to do it. If you call some of these offices, they say, "We don't know. You have to go to the legislation." We're like, "But this is your regulation."
that's what I
There,
was told. Exactly what I was told.
that's exact, right? So
Yeah,
it's like, okay, now I've spent an hour trying to get somebody on the phone. I've already been on the website. This doesn't even include once I get the regulation. Now I got to figure out the right course to do, what counts for it, what doesn't. And we haven't even gotten into whether the course is good or not, right? And is it quality? Is it something I'm going to learn from? So what does it become? It's become a box checking activity, right? People turn on the video and they leave it going on in the background. How is that improving patient safety and patient care? That is not what our legislators and our regulators are even trying to accomplish, but that's the outcome we're getting because we've put so much work on the front end that by the time somebody gets there, they're exhausted and they're like, forget this. Like, I'm going to hit the button, I'm going to finish the quiz, and hopefully I pass it, and maybe I can retake it. We've got to change the whole workflow to get back to why do these things exist in the first place?
exactly.
Safer care, better care. At the end of the day, that's what it's about.
I'm a very transparent person. I don't know if it's the same on the physician side, but how many times where it's, oh yeah, I need some CE credits. Oh, did you talk to so and so who just did this? Have you ever used this test before? I have the answers to this one. What does that do? What does that do for the actual patient experience and for that healthcare provider? It's out the window. It's making it obsolete. It really is.
It really is. And so where do you start? You start by the most painful part of it and fix that first, right? And so that's where what we feel like we have fixed. And we're seeing that in the market now with the uptake of our product. Our goal is to fix much more than that, right? Because you can't stop there. You really have to keep going and saying, okay, now that we have this infrastructure to deliver the right education at the right time. And we have the technology now to really learn about our learners and say what kind of activities do they need? What kind of activities may they want to learn? Can we learn about their practice and what they're delivering as part of care? Maybe we can start delivering, and we can, and we plan to start delivering education in smaller little buckets that actually go towards their requirements, but are making them better at delivering care on a daily basis. Like if you are starting to integrate this into somebody's workflow and their professional lives, my dad, and by the way, you're in Stony Brook. My dad was on staff at Stony Brook University Hospital, pediatrician
Yeah.
in Long Island and Port Jefferson. His office was in Mount Sinai. My dad, I used to remember going to the hospital with him to round, and in the car, he'd put the cassette in and he'd listen. And I just remember from back then, I was like, Dad, are you actually listening to this? Because this could put me to sleep in 30 seconds, right? Like, you need to have things that are relevant, that are education, that is what that person is going to go into clinic and see and apply that education. Because if they learned something at a conference and they went to Hawaii to do it and they spent more time on the beach than actually learning,
Hmm?
that's fine.
Yeah.
But the learning that they actually did, when is that actually going to get applied? 6 months later, are they going to remember that? We can leverage technology in such a way that we'll reap huge benefits from the continuing education. We just have to set up a different system to do it.
Yeah. So, do you, and if you do, how has your experience as teaching, like, a teaching faculty member, influenced your approach to developing Mockingbird as a whole?
I think that being a learner and being a teacher, I probably do a little less teaching at courses now than I used to. I used to do quite a bit. And I used to be on the academic faculty up in Syracuse, at SUNY Upstate. And I'm now in private practice. I spend more time with teaching physician assistants and teaching other types of clinicians about orthopedics.
Hmm.
So I've taught a lot of different type of people over time. I'll tell you the thing that I've learned there is that the way people learn is just really varied, and you have to meet the learner where they're at. You cannot say a one size fits all type of activity is the way you're going to get across the information to somebody and have them become better at what they do. And again, it's focusing more on the learner and less on how we need to disseminate information or the person creating the content. There's tons of content creators that are out there, and I think that they're all trying to do the best that they can.
Yeah.
But a lot of content that's created in the healthcare space, in the continuing education space, is either grant based. We're seeing a lot of that go away because of the budget cuts that we're seeing. It's industry based, and there's obviously bias there, right?
Yeah.
But they're filling a hole and they're filling a
Yeah.
need, and it's not based on learners' needs at the time. And then the way it's coming out, we're definitely seeing better uptake on, people have podcasts, people have webinars, people have just straight PowerPoint lectures that are out there. There's a ton of different options that are out there, but short form content, how can you get like 5 minutes of learning in somebody's hands? AI tools are great, but can you rely on them, right? Am I going to rely on this or wonder if there's hallucinations in the chat GPT when I'm asking it
Yeah.
about give me a summary of the three most recent articles on this?
Yeah.
We're not there yet, right? And so all of these tools need to be integrated in what we do. But as a teacher, I have really realized over time that you can't rely on one modality for the whole population. Every learner is different, and we need to be able to give people different opportunities to engage with content, and also different times and different locations. Some people need to be in person, and I don't think you're going to see those live activities go away. Some people learn really well while listening. Some people are more visual learners, right? So I think that it's having a wide variety of opportunities for people is what's going to be most effective in teaching, the clinicians in the future.
Awesome. Awesome. So the question that I've been the most excited for is, so how do you balance, you don't teach as much, you touched on that, but how do you balance your role, as a practicing surgeon, educator, which clearly you said, they don't teach as much anymore. And being the company's, CEO, what does that look like on your end?
One of the reasons I don't teach as much anymore is because just being an entrepreneur and being a clinician takes up. I mean, my wife is an OBGYN. She recently um, stopped practicing, but in the past several years, and that's allowed me more time because she's more supportive of the four kids that we have at home, right? And then, yeah, I have a full-time practice, and it's sometimes it's spinning plates with trying to make sure that everything gets their due, including my family. But it's also relying on a really strong team, right? Ian Madom is this entrepreneur that built Mockingbird. No, he didn't. His team built Mockingbird, right? I have probably one of the strongest teams in the market. And I see that in the feedback that we get. We have people that work with us at Mockingbird that really feel passionate about the mission that we have to improve clinicians' lives and improve the admins' lives that support, those that are out there supporting clinicians. Having the right team around you, whether it be at Mockingbird with those folks, at Ortho Rhode Island where I practice, the team that I have at home with the teammate and my wife, right, and even my kids, having the right folks around you and showing your deep appreciation for those folks and giving back to them, that is what ends up making you successful because you cannot do it alone. You need to really get the help of others around you to believe in what you're trying to accomplish.
Yes, you speak right to my soul. People ask me all the time, how are you, running four different practices as a director? You have two little kids. S- Rivera AI Solutions, the new business that it's the team. It's everybody. I always say too, my wife, she's the MVP. Without her, with the two little kids, we just went and got a new dog. We need another challenge, And that's good, right? But somebody just asked me, "Are you crazy?" It was 2 weeks ago. I said, "It's the people I'm supported around." So.
Listen, you can take on more. You can always take on more than you think. But and you always have to. The power of saying no, I think, is important too at times. But the having the right team around you, showing them the appreciation. Also, with team, it means like that you're not just going to have your hands in everything, and that there's trust, right? And that you believe in other people to let them grow and let them take on challenges and it gives them an opportunity to lead, right? I feel like as a leader, in the various things that I do, the best thing that I can do is show other people the way of leading and give them opportunities to really lead, and then be there as support, as a source of feedback, as a cheerleader. That's how you obtain any big goal is just building other leaders around you.
Absolutely. So my final question I'll leave with, for medical professionals listening who are frustrated with their current credential management process, what's that first step that they should take?
Yeah. I'd say I'd answer that in two ways. First way is for their own credentials, go on the App Store. You can download Mockingbird, right? Our B2B is a little wonky. There's a couple extra steps there, but you can really manage a lot of things on it, especially if you have more than two state licenses. A lot of folks in the New York area do, especially in the tri-state area. They have Connecticut, they have New Jersey, they have New York. We simplify all of that and it's pretty cheap to do, right, on a yearly basis. If you want to do that, if you want to come check it out, the UI, UX, it's all built by clinicians. Like we brought in a whole bunch of people that deliver care and we put it in their hands. And that's what we continue to do. We put it in people's hands and we take the feedback and we continue to improve on it. And we really run the full from initial licensing to that management to even the renewal piece is challenging for folks, and we take that on for people and help them do it. But there's also many of my colleagues out there, not just physicians, any type of clinical care folk that they see that challenge in the market, right? They see that challenge to their colleagues, and they say, "I could fix this." There's so many pieces of off-the-shelf AI things that you don't need to know how to code. Go build a prototype and show it to your colleagues and say, hey, what do you think about this? Do you think that this would work? And go build something. You don't need to be a software engineer to know how to solve a problem. As it gets bigger, you need software engineers. They're going to
Yeah.
figure out how to
Going back to
operation.
that teamwork, you know?
That's get back to the teamwork. But
Yeah.
at first, you all know the problems that are in healthcare. I'm not trying to speak badly about the CEOs of health systems. They're not going to solve our big problems. We're going to solve our own problems. At the end of the day, if we really want to solve the problems of clinicians and make our lives better, we need to bring tools to the market to allow our workflows and our lives to be better so we can get back to the bedside, taking care of people, and even just as important, get home a little earlier to be with our loved ones.
I love it. I love it. And I know you mentioned the app, Mockingbird. Any other places, website, Facebook, Instagram, where can the audience find you? All
Yeah, you
over?
can find us at Mockingbird. So it's Mocingbird, Mockingbird. There's no K. The MOC is maintenance of certification, which is a ugly word for a lot of people, but we're trying to make it not so ugly. So it's Mockingbird without a K for maintenance of certification.
All right. Well, Dr. Madom, I appreciate your time. Conversation was fantastic.
Thanks, Nick.
The audience going to learn everything. And yeah, listen, I just very much appreciate you being on the show. And
Thank you.
you have a great night. All right.
Thank you. You too. Be well.
All right. Take care.